Positive change can be defined as the act of becoming better. The operative word here is becoming, something occurring over time. Over the last 20 years, the number of children who die each year from malaria has dropped by around 60%. Positive global interventions have saved 7.6 million lives. Bad news is that the rate of decline is now all but stopped. Over 409,000 people, mostly children, died from malaria last year, despite the distribution of over 34 million mosquito nets since 2004. This is the problem in a nutshell. Malaria control efforts have worked well in countries that are stable and at peace, but basic mosquito nets and conventional healthcare services aren't as effective in poor, war-torn countries with high disease burdens where deaths from malaria are actually increasing. We take you now to South Sudan, with a population of just 11 million people, where malaria is still on the rise, with 1.9 million people infected in 2019. It is the leading cause of death, one of the worst in the world.
So we're on our way to Maban. It's the first place we really got to work in South Sudan in 2012. And we came in when the UNHCR pulled us in a bit of a panic because malaria was out of control in refugee camps that were being formed as we spoke.
Journey alongside Mentor's dynamic team as they travel around the country, working to save lives in an arduous endeavor built around science and deep understanding of the country and its people.
This is the MSF outpatient department where we run outpatient services. What is happening at the back here is a malaria screening point where children and vulnerable groups are tested for malaria.
MSF has been present in Maban for the last 10 years. We initially came in response to an acute situation because of the refugee flow that came from Blue Nile State. But as the situation has changed, today there are many partners taking care of refugees.
We are the main agency that does the coordination of all the different partners. We have more than 23 partners, and we are dealing with all the different sectors in health, in education, in water and sanitation, in protection, which includes also sexual and gender-based violence.
It is through partnerships with other NGOs that we are able to achieve our best work.
So we're in one of the 4 big camps here that house about 145,000 refugees.
People who are living here in Doro refugee camp, they came from Blue Nile, Sudan.
In 2009, 2011, there were conflicts between the Sudan army forces, the SAF, and some of the rebel groups. A lot of this political conflict ended up in war, and a lot of women and children who were not party to any of these political affiliations were affected, and they ran across the Blue Nile, and they managed to come into Maban County, and this is where UNHCR had to step in because people were suffering, they were displaced, they had crossed the international borders, hence they are refugees. And this is where UNHCR has a mandate to now protect those who are vulnerable, those who have ran away from conflict.
When the war started in Sudan among themselves, and they flew here, they were much welcomed by the South Sudanese, because with the Wuduk people and the Mabanese, they have actually, when you look at them, they even speak the same language. So sometimes when they are here, they feel comfortable, and also they get services from the NGOs.
This particular one is the first that they made back in about 2011-12, started to form, and it's got now 45,000 people living here in still pretty much unchanged shelters from 2011-12.
As long as they stay here, because when you look at them with the Mabanese people who have the land here, their relationship is getting tired.
So the host community felt very bad about that because they were seeing us doing malaria control prevention in the refugee camps, but because of no funding, we were unable to do it in the host community.
We cannot have on one side where you're supporting the refugees, but the host community is in a dire state. So we have to make sure that both communities benefit as well from this assistance that we can provide.
We received funding in 2018, and since then we have been doing the same activities which we were doing in the refugee camps.
So we're in the host population, which is just on the side of the refugee camps. And this host population is almost inseparable from the refugee camps themselves. You'll see that these shelters look very much like a refugee shelter, but these are host population. They've been living in Maban for a long time, and these are the guys that have welcomed in people who are probably better supported than they are. The Mentor Initiative team is working with the host population in exactly the same way as we do with the refugees, because they're just as affected by malaria as the refugees are. You can see this lady behind us. She's living with 6 people in a piece of plastic sheeting, and she's been there for years. She doesn't have all of the same advantages of being a refugee, but for us, we treat them, everybody is the same, because everybody's at the same risk of disease. She's got 5 children in there. Most of them will be highly vulnerable to disease because they're so young.
Malaria data is decreasing in the host community the way it used to decrease in the refugee camps, so they are happy now, and we have very good relationship with authorities because they see us doing something even for their communities in addition to what we are doing in the host community.
I think one of the major challenges that currently we are facing is the floods. I think if you have traveled around Maban County, we have seen unprecedented levels of flooding.
You look around you and you see the amount of water on the ground. Here when it rains like nowhere else. And it rains between July, June, sometimes earlier, right the way through to November. But the mosquitoes that transmit malaria, they breed by putting their eggs onto the surface of the water. So wherever you have water in this refugee camp, you have mosquitoes laying their eggs.
When you have stagnant water caused by flooding, then you have malaria.
That it is endemic in this part of world. So we are really having high number of mortalities.
Even with a net that works, even with insecticide that kills the mosquito, as you drive around these camps and you see the flooded areas, the most common sight you see is children or adults in the floodwater with their mosquito net, using it as a fishing net. Because for them, the practicality of the net just lends itself to being abused. If you look at the shelters around here, you can see that they're pretty open. They're not very well made. They've got open doorways, they've got slits in their walls. So when it rains and the mosquito population is going crazy, it goes exponentially through the roof. The adult mosquitoes, they will fly into the houses every night, and you could have thousands of mosquitoes in a house. One mosquito in 100 may be infected with the parasite that is malaria, the Plasmodium parasite. But if you're bitten 20 times in an hour every evening, and you wake up in the morning, you've had 200 bites, the chances of you not being infected with malaria are infinitesimally small. So it means the health facilities here are packed full of malaria cases if we haven't protected those houses and made the houses more difficult for mosquitoes to enter.
It's very predictable to know when malaria will come. And for this, we need to put control measures that are running throughout the year. And for us not to see what we see in terms of the burden here in the facilities, because at times it can get overwhelming for the healthcare staff. But if we are able to reduce this and be able to concentrate on other aspects that are not very highly predictable, like malaria, it would be good.
IRS spraying and vector control, it's not a program, it's a policy. It's a long-term necessity to be able to control and to bring down malaria. It's in terms of incidence and prevalence.
And this is where, partners, operational partners like Mentor Initiative come in and do very critical work for the operations to reduce the rate of malaria in both the refugee and the host communities.
So the way we protect people in this camp is we've got a team of people who work in the camp through the year, but just before the rains and as the rains are starting, we go into every single shelter and we spray the inside surface area of the walls with an insecticide that kills mosquitoes. And that stays on the wall surface for up to 9 months. When a mosquito lands on it, and they must after they've bitten somebody because they're filled with blood, they can't fly very far, so they rest on the first vertical surface that they can find, which is a wall. If it's been sprayed by us, that mosquito will die within the next few minutes and it won't be able to complete its life cycle and go on to infect anybody else. So we come in and we spray shelters all around us. So this lady is from the community here. She's a normal member of society, but when we run our teams, we come in and we work with the authorities in the villages to select candidates who they think are trustworthy and will be trusted by the local community. It's really important that our sprayers are not from other areas because they have to go into the most intimate environment, and we need to get access into at least 85% of all the shelters in order to create a community protection.
We do not maintain a large team. We hire people from the MOH on a daily wage base. We train them and they deliver the activities for us. So not only they deliver the activities, but we are also enhancing their skills.
We have 2 people working together. One is trained to talk to the shelter occupants and the other is trained to spray. And they'll move as a pair, known by the community because they're from the community. But we've trained them how to do spraying properly. We've trained them how to do the mobilization, explain to the households what's going to happen and what they need to do, and to get their cooperation, because the household has to want this spray to come in. And the other reason is we want to be able to come back on an annual basis when we have to repeat spraying, because malaria comes with the rainy season and it doesn't stop once we've sprayed. It just is protected for that year, the shelters. It means next year when we come back in, we can mobilise the same families, the same households, the same sprayers who we trained before, the same supervisors. They're ready to go. What we're doing is creating a whole cadre of people who have awareness, understanding and a skill set that can take on other activities that might be the activity which follows indoor residual spraying as the longer term way of protecting against malaria. Because indoor residual spraying is fantastic, it's really effective with the right chemistry, but we're always fighting a battle with the mosquito for what comes next. So new solutions, and I've got one, and it's the new pipeline tool. Its usage is as a spatial repellent. And when you open this up, and you literally just open the paper, the transfluthrin that this plastic has been impregnated with now will start acting. If I hang that or stick it onto the inside of this shelter, it will simply repel all the insects that come into the shelter, and it will keep going for a month. Is it as good as indoor residual spraying? We don't know. That's why we've got 4 studies going on, 1 in Syria, 1 in Yemen, 1 in Nigeria, and now we're looking at bringing this in here because we believe that innovation is critical to, 1, achieving good disease control, and then 2, to sustaining it as the challenges of insects mount up every year. It's really important to evaluate tools, not in a laboratory, yes, first to check that they actually work, but most importantly to evaluate tools in the context in which they're going to have to be used. Because if we can move away from indoor residual spraying and nets and make something as simple as this available to communities for a few cents, and just teach people how to use this with simple pictograms as a way for communities to take a larger part in their disease control.
And it needs continuous efforts in order to decrease the cases. And we have seen that since we have partners, operational partners such as Mentor Initiative, we have seen that the cases of malaria has reduced, and this is saving lives basically.
So to give you an example of how well it works, in one camp we monitored very carefully the impact, and we saw before spraying ever began, there were about 188,000 cases in that year. 1 in 10 people who get infected with malaria in this setting will end up with severe malaria. And that 1 in 10 has a 40% chance of dying even if they're treated. Because they're little children like this. They're so young, their immune systems haven't developed. So they're extraordinarily at risk once they get sick with severe malaria. As soon as we'd sprayed the following year, there were only 50-something thousand cases. So we were able to cut it dramatically. So we know if we've reduced the number of infections by 130,000, that 130,000 contains 13,000 people who would have had severe malaria that year. And I put my hand on my heart and say, at least 10,000 of those were saved and would have died had we not been able to stop them getting disease in the first place. You can roll that in every year. How many children have been saved? And I'm guessing conservatively it's not far off 100,000 children are alive today that wouldn't have been if we hadn't been working in these camps. It's probably the most cost-effective intervention you can do in an emergency where malaria is the key killer.
Keeping our operational costs to the minimum possible. For example, I am sure more than 70% of the funding that we are getting from the donor is going actually to those activities, to get them those deliverables. So large part of the funding is going to actually implementation of the activity.
We believe the cost for a whole year of us being here. So that means spraying every house every year, supporting every health facility, training the health workers, doing all the education in the schools and across the camp to get people to use the facilities, to get people to allow us to come in and spray. That work costs $3 per person per year for the entirety of services.
We don't just save lives. When you cut disease transmission by 80%. You change everything in the health system. The health facilities are often run by other very competent NGOs. Now can actually concentrate on doing the job because they're not overrun by cases of malaria.
Basically, we are serving both the host community and the refugee community.
And how does that work out? How do the host community and the refugee community get on with each other in terms of using the services? Because we've had tension in the past between the two.
Yes, we try to bring all that together. We don't. We try to make them feel like they're brothers and sisters.
Yep.
Yeah. Basically, that's why we're here.
And tell us a little bit more. Malaria is what I've done all my life.
Yes.
And I started with severe pediatric malaria and new drugs and looking for new cures. It's very emotional. It's very draining when parents bring in severe malaria children.
Yeah.
You must see a lot of children brought in who are in a terrible state.
The severe cases are the ones who go unattended for a long time. Those areas that are quite far and people tend to get here after 5 days. Yeah. So you find maybe a family, the mother has malaria, the dad has malaria, yeah. They're carrying like 4 kids with them. And you're here at night with a child who's really, really sick. Some of them just get here on time.
Yeah.
But we've had sad cases of some who pass away on the road and they don't even get here.
Yeah.
The burden is mostly on the under 5s. But I can say we've had medications which are really helpful, like Artisan, which you've been supporting us with.
I think back to when we began, and everybody was using quinine,
yeah.
A really complicated drug to administer with 24-hour nursing. And it was Malacal and Maban where the ministry gave us first permission to pilot this new drug recommended by WHO, easy administration. At that time it was revolutionary in this country because nobody was using it anywhere. And within a year, I think, the ministry had adopted it, brought it into the national protocol. Global Fund and everybody else was starting to buy it because they could see what was happening in Maban and Malacal. And they could see it wasn't only recommended, but it was easy to use and had an impact. And I just wonder what sort of impact it had in the hospital, the changeover, and what you saw in that.
I've seen even the under fives, their response is quite remarkable.
Yeah, I've seen children get up who were flat, paralysed, unable to move within an afternoon after injections of...
That is true. I've seen even people bring in children here who they're ready to bury.
Yeah.
They, here the community does put all these ornaments on them, and they have them ready because they see these children are going to die.
Dying, yeah.
With the artisan, I think it's a wonder drug. Thank you to whoever discovered it. Thank you for for making it available. It's quite good. It really helps. And I can say so many lives have been saved through the use of this drug.
We are changing things, and it's possible to change things very fast if you have a team of dedicated people, some of whom are experts, but an awful lot of them are just good people who you train to do the right jobs in the right place in a team, and who are willing to take a risk. Because every single person who works for me comes into situations where their lives are not stable or secure.
But the reality is life is not always easy at the field level. But we are here for a cause. We are serving the local community, so mostly we eat what they eat, like say beans, rice, and whatever is available here. And we stay in a modest compound without 24/7 electricity, without running water. But we are here for the cause, and we are working to achieve that cause.
And there are very real threats to them. And many of our teams experience armed gunmen. They end up being in areas which have heavy active fighting. But that's a risk that I think everybody on my team, and I'm hugely proud of them, would just say they're willing to take, because we see so many lives changed so quickly in a crisis that it makes your life satisfying, makes something worth doing.
What brought me to mentor is that they are saving life.
This work, if you do it well, the case load from the health facility will tell about the quality of your interventions. If you do it well, in a proper way, under WHO guidelines, then the malaria cases will reduce, and your work will speak for you in terms of reduction in the malaria cases. It's not like other activities where you go implement and nobody would see any impact. So here you can see the impact.
I was employed by Oxford University to come in as a research assistant into a program where they were developing drugs for pediatric treatment of severe malaria. And my first job, I was sent to the Gambia to trial a new drug treatment. And my job as the young rookie in this research team was to meet the parents who were carrying their sick children, and some had been carrying them for days across the Gambia to get to this facility. They'd hand their children to me, and the number of children I took off their hands who were dead and they didn't realize. And it was heartbreaking. And I'd have to sit with the parents afterwards, with the ones who were alive, and give them hope and tell them what to expect, which was pretty miraculous, because within a couple of days they could be up on their feet and moving again. But the number of parents I had to sit with and mourn with, because their children were handed to me dead, and they had to leave mourning, taking a body back to bury, it just convicted me as a young man that something more had to be done.
So you can imagine how many lives, how many children's lives we might have saved. So that is something that gave me pleasure, or what you call it, like satisfaction. I'm doing something for the community.
I just felt we could do it better. I just felt we could bring it to the people and do things quicker, cleaner, more effectively, and save more lives if we had a whole team of people just dedicated to really changing what happens on the ground.
I'm saving lives. I'm part of the team which saves lives.
But when you're dealing with these children, I can honestly say most of them wouldn't exist if we hadn't been here for the last nearly a decade.
For the Visionaries, I'm Sam Waterston.